lumbar stenosis is any cause, predominantly it's degenerative, which causes narrowing of the central canal. So, as I said, the most common cause is degenerative, so that's wear and tear. You can also get it from inflammatory conditions, tumors, infection, trauma. But generally speaking, we tend to see it in the context of wear and tear. And from a patient perspective, they're going to complain of heaviness, fatigability, weakness, tiredness of their legs. So they'll find that when they're upright, standing and walking, that their standing time and their walking distance become impaired. And it's only relieved when they try and sit down or stop. So that's sort of the most common classical presentation. So I think it very much starts off with a detailed history, physical examination, including checking for pulses, because you can also get claudication, which is the heaviness that we talked about, in vascular conditions, not just when you've got narrowing in the spine. It's also important to realize that I see a lot of patients who come in with lumbar stenotic problems, but then I also diagnose that they've got similar stenosis within the neck. So 1 in 5 patients may have this without realizing it, and they may put this down to old age, arthritis, carpal tunnel syndrome. So it starts off with a detailed examination and history. And then really the gold standard is an MRI. So that's it's a modality of imaging which doesn't use any radiation. It's very safe. Some patients may not like it because they might feel a bit claustrophobic, but then we do have options for open scans. And it generates a lot of detailed 3-dimensional information about the anatomy, particularly looking at the nerves. And then once the diagnosis is confirmed, I inevitably also request standing x-rays of the spine with the patient bending, and it's telling me, is there a dynamic element to their pain? Because sometimes the alignment of the spine can change as one bends forwards and backwards. I suppose, like anything, treatment depends on bespoking to the patient in front of you. So the same treatment isn't applicable to each patient, and it's basically given on their own merit. So their expectations, their functional capacity, their pre-morbid level of health. So somebody who's got a lot of risk factors, is functionally very low demand, may not want to consider, or may be too high risk to consider surgery, whereas somebody who's younger and was very independent and has now lost their independence may actually be an ideal candidate for surgery. So broadly speaking, most conservative is the use of a walking aid. So a trolley or crutches, which allow the individual to lean forward. Leaning forward opens up the spine. It opens up the central canal, which allows more blood flow, more oxygen. So it delays the onset of symptoms in the legs and allows that person to walk and stand for longer. But that option may not be accepted by people who are much younger or who used to be very independent. And in that case, really the gold standard treatment is surgery, whether it's just a decompression, that's to remove bone and ligaments using a high-speed burr under the magnification of a microscope. Sometimes we also need to put in screws, and that's all done as a part of a preoperative planning where x-rays will show me if there's any instability, and so I can plan that before the surgery. Injections Whereas they might be useful for sciatica, they're not really particularly useful in this pathology, although sometimes patients will want to try it because they do not want to consider surgery. But then I will sort of explain that it's likely the symptoms will not go, or they may return quite quickly after. So a typical claudican will get symptoms of heaviness, tiredness, fatigability, pins and needles, loss of balance when they're upright. And that's because when you stand up straight, you extend the spine, and then that narrows the spinal canal. It limits the amount of blood and oxygen to the nerves and to the muscles. So if you bend forwards, it opens up the spinal canal. It allows more blood to go in. So you might find people compensate subconsciously by walking more stooped forward. You might find that purchasing some walking aids will be useful. You may even find that cycling instead of walking gives you that level of independence because you're sat forward flexed over a bicycle. And I regularly come across patients who say, look, I can cycle as much as you want. Or if I go shopping, I can lean forward on the shopping trolley and I'm fine. But I can't walk 50 yards unsupported. So these are some lifestyle changes you can try. You can also try some nerve type painkillers such as amitriptyline, pregabalin, gabapentin. These sometimes might help. It's important that obviously if you experience any dysfunction of bladder or bowel control, so you start to become very urgent, you can't hold your urine, or you can't feel that you need to go and you wet yourself, or you're getting any pins and needles or numbness, you must attend your local hospital immediately without delay, because these are symptoms of a possible cauda equina syndrome, and that's because of compression of the nerves in the context of spinal stenosis.